Hi everyone, welcome to my presentation on patient-reported outcomes in athletes with ankle sprains. The patients targeted for this project were athletes with ankle sprains who had the potential for activity limitations at the task level and impairments at the body level of the ICF disablement model. Many athletes this spring season have been reporting to the athletic training room with ankle sprains, and it is one of the injuries that our school most commonly sees and that we most commonly evaluate in the athletic training room and that we treat throughout the school year, which is why I decided to focus on that for my project. The generic PRO assessment I decided to use for my project is the Pediatric Quality of Life Inventory 4.0 Generic Core Scale, abbreviated as the PEDS-QL. I chose this because it addresses health-related quality of life in children under the age of 18. It uses a 5-point Likert scale for scoring, with higher numbers relating to higher quality of life. The scoring system is reversed, however, so the sum of the items is divided by the number of items answered. But as you can see on the right, a lower rating of 0 equates to a higher score of 100. So 0 never is 100. A rating of 1 almost never is scored as a 75. 2 sometimes is scored as a 50. 3 often is scored as a 25. And 4 almost always is scored as a 0. We can assess either their physical health-related quality of life using the Physical Health Summary Score, the Psychosocial HRQOL using the Psychosocial Health Summary Score, or both of them together using the Total Summary Score. For my project, I focused on the Total Summary Score. A thing to note is the minimal clinically important difference, or the MCID, is 4.4 for the child self-report, which is what I used in my project. The specific patient-reported outcome assessment I used is the Foot and Ankle Ability Measure, abbreviated FAAM. This assessment has 2 portions, an ADL subset, which has 21 items, and a sports subset, which has 8 items, and each of those sections is scored separately. So each item is rated by the patient from 0 to 4, 4 meaning that they have no difficulty with the task, and 0 meaning that they are unable to perform the task. The ADL portion is scored out of 84, and the sports section is scored out of 32. 32. Note that the non-scored items do not count against the final score, so if an athlete left 1 blank on the ADL portion, instead of being out of 84, it would be out of 80, and so on. So the total score for each section is found by dividing the score given by the patient and then dividing that by the total points available. So if they reported 56, a rating of 56, you would divide that by 84 to get their percentage, or to get the decimal, and then you would multiply it by 100 to get a percentage. So the higher the percentage, the better the ankle function that the patient is reporting. The MCID for the FAAM is 8% for the ADL subset and 9% for the sports subset. So I completed the first assessment either after the initial evaluation, if it was a new injury, or prior to beginning the rehabilitation exercises for that day, on whatever day the athlete was doing their assessment. They completed their patient-reported outcome assessments 2 weeks apart, and I did this to the day. So if they did it on a Wednesday the first time, they would do it on a Wednesday the second time. Some athletes were almost fully returned or had fully returned to sports at this time. Others had just started integrating little things into practice so they could jog or do things like that, but they were not participating fully or even very much in the sport. And they completed their assessments individually after clear instructions were given and any questions were answered. For the FAAM, both the ADL and the sports subsets were completed at both times of assessment. For the PEDS-QL assessment data, I will go over the chart that's on the right. So the first subject, their first PEDS-QL score was a 57.61. Their second score was an 84.78. The second subject, their first score was an 58.70, and their second score was an 85.87. The third subject, their first score was a 32.61, and their second score was a 65.22. The fourth subject, their first score was a 46.74, and the second was an 83.70. And finally, the fifth subject had a PEDS QL1 score of 56.52 and a second score of 66.30. And all of those show clinically important change, and we will discuss that in a couple slides. For the FAAM data, I have both the ADL and sports subsets separated, so I will again go over this. So the subject 1, the first ADL score was 35.71, and the second was 83.33, and those are percentages. The first sports score was 15.62%, and the second was 75%. Subject 2, their first ADL score was 59.52%, and their second was 97.62%. Their first sports score was 56.25%, and their second score was 87.5%. The third subject, their first ADL score was 14.29%, and their second score was 80.95%. Their first sports score was 3.13%, and their second score was 68.75%. And I believe that is the biggest jump that we had besides subject 4, which subject 4 had 25% for their first ADL subset, and their second ADL score was 70.23, and then this is the biggest change of them all. They went from a 1.25 on their first sports subset score to a 71.88% on their second. And subject 5 had an initial ADL score of 53.57 and a second one of 80.95. And the first sports subset score was 56.25%, and their second was 84.38%. Digging a little deeper and interpreting this data, all of the athletes' scores did improve from the first to the second assessment. I do believe that this is due to a combination of techniques. So in addition to just the rehabilitation exercises, we also used rest during the acute stage. We did range of motion work at the school and also gave them a home exercise program to continue range of motion at home. We use cold therapies such as ice buckets, Game Ready, E-Stim, and ice for a patient who had this prescribed by their physician. We also used milk massage to help inflammation that was pooling in the ankle for any patients. Our rehabilitation exercises followed the same basic pattern, but our exercises were adjusted for each patient as needed on a case-by-case basis. So we started with range of motion and getting that back to as normal as possible. And then we moved on to static exercises. From there, we would progress those to more dynamic and finally more functional and sport-specific movements before returning them to their sport. Improvements were determined based off the MCID values that we discussed earlier that I pointed out. So the PEDS QL MCID is 4.4. The FAAM ADL subset is 8%, and the sports subset is 9%. So all changes in all of those scores that were on the past two charts are more than those values, which means that they were clinically significant improvements. Something I did find interesting and that got me thinking a bit was that the data was collected nearing the time of playoffs at my school. So I'm wondering if this could have impacted athletes' answers if they thought that this would help them return to play faster. For example, subjects 3 and subject 5 had similar PEDS QL2 scores, but subject 3 was still restricted in return to play, and subject 5 had fully returned to play. So remember, subject 3 had a 65.22 and subject 5 had a 66.30, and yet they were not in the same area of return to play. So one had fully returned and one was only partially returned. And then another interesting one similar to that is in the FAAM2 sports subset. Subject 1 and Subject 4 had similar scores. So Subject 1 had fully returned to play, and Subject 4 was still limited in the time they were allowed to play in games due to fatigue and pain with continued activity. But patient one's subset score for sports subset score for their second one was 75%, and patient four's score was 71.88%. So again, they are similar, and yet they're in two separate different portions of their own return to play. Overall, I thought this project was a great introduction to PRO assessments and their use in athletic training. Some barriers that I specifically faced were time barrier, so it was difficult to find time for the athlete to complete the assessment once they had participated in practice. So these athletes would have to come in and do their rehab before going out to practice, so they would already be a few minutes late. And then on the day that it came to completing their second PRO assessment, most of them found it difficult and somewhat challenging and inconvenient to have to complete the PRO before they started their rehab, before they went out to practice. So a way that I found to get around this was to have them complete this while they were heating prior to their rehab exercises. So most of them heated their calves before starting, because we always would stretch their calves, and most of my athletes just tend to like to heat before they do so. So during that 5 or 10 minutes when they were already going to be doing nothing but heating, I just had them complete the assessment then, and it really cut down on that time barrier and helped with that a lot. The other barrier I faced was lack of support from coworkers. So my coworkers, I have two of them, both were like me before this course and have never used PRO assessments, and they were not educated on them and did not understand their benefits or really how to even use them in the best way. So I found that education was the best way to overcome this one. So I would educate them on the benefits of the outcome assessments, and how simple it could be if we chose the right measures and things of that nature. And by the end of the project, they were interested and were watching intently as I would score and discuss with the patients, the athletes, on what they were going to be doing. And we have decided that starting next year, we will be deciding to incorporate some of these on a regular basis. So they definitely did come around by the end, but at the beginning, this was a barrier for me. A success I had during this project was using the PROs to assist with clinical decision making. So I noticed that as patients were self-reporting improvements, they were also showing functional improvements in their rehab. So this allowed me to recognize that not only did I think they were ready for more challenging exercises or even to start returning to play, but they also thought that they were ready to progress, as was evident with their self-reported outcomes. A challenge I'd faced is on a similar note, but a little bit different. So it was with making return to play decisions, specifically using PRO measures as a factor. So in situations like patient 4, who scored a 71.88% on their second FAAM sports subset score, should they be returning to play? This athlete was one step away from fully returning, as we were only limiting the minutes that she spent on the field. We weren't any longer limiting the activities that she could do while she was playing, just the time that she was on the field playing. So is a self-reported outcome score of 71.88 enough for this patient to feel confident to return to play? On a similar note, patient 1, who scored the 75% on his second FAAM sports subset, he had also returned to play, but he was full return with no restrictions and had moved into a maintenance exercise program only. So for those two athletes, are those lack of outcome measures, or are those not quite as good outcome measures, being only in the 70s? Is that enough to return them to play? Both of these athletes were performing well functionally, otherwise they would not have been allowed to return to play, and they were either partially or fully back, but their FAAM sports subset score that were their self-reported outcomes did not reflect that they would be ready to return, in my opinion. Upon questioning them about this, they both did state that they were ready to return to play and only had minor pain or discomfort while playing. But if that was the case, I would have expected to see higher percentages on those. So this brings me back to my question regarding the timing of this project being near playoffs at my school. Could this have impacted what they were saying to me versus their results that they were putting on paper when they were only filling it out for themselves? In other words, could they have been playing through more pain than they were showing in order to return to participation? As I continue to implement these outcome assessments, I will become more comfortable with this, I'm sure, but I would be interested in hearing anyone's thoughts on these subjects specifically, as well as the subject of using patient-reported outcome assessments to influence return to play decisions. I hope you all enjoyed my presentation. Thank you for listening, and I'm looking forward to any feedback and conversation in the discussion board. When I began collecting my outcomes data, I identified athletes who either had just sustained ankle sprains or were already being treated for an ankle sprain. So 3 of my subjects began completing their assessments on the same day that they sustained their injury, and 2 subjects had already been participating in a rehabilitation program. So you can see subject 1 completed their first one at the time of injury, and their second one, and by the time they had completed their second one, they were already back to full participation with the maintenance program. Subject 2, their first outcome assessment was done 2 weeks post-injury, as they were one who had already started before the project information was given out and collection started. And the time of their second assessment, they had been participating fully with the maintenance program. Subject 3, their first assessment was done at the time of injury, and by the time of their second assessment, they were participating in modified participation, so they were not able to jump or do any aggressive cutting or quick change of directions. Subject 4, the first assessment was done 1 week post-injury, and at the time of the second assessment, they were doing modified participation as well, but they were only limited to a limitation of game time to allow for more frequent breaks before they made the final return to full play. And subject 5, their first assessment was done at the time of injury, and their second assessment, they were fully participating with the maintenance program.